Okay. အားလုံးပဲမင်္ဂလာပါကျွန်တော်ကတော့ Himex Mandala Association Garden ရဲ့ Medical Advisor တော်တော်ရေးဆောင်ပါဒီနေ့ကျွန်တော်ပြုလုပ်ခြင်းပါတယ်ပေါ့နော်ဒီ updates on the management of HR positive advanced breast cancer webinar လေးကိုတက်ရောက်ပေးကြတယ်ဆရာမများအားလုံးကိုရောက်ချင်းစီကိုကျွန်တော်ထူးပဲကျေးဇူးတင်ရှိပါတယ်ဒီနေ့ပွဲလေးကတော့ကျွန်တော်တို့ပေါ့နော်ဒီ updated on the management of HR positive breast cancer ကိုကျွန်တော်တို့ရဲ့ဒီလေးစားပါတော့ကျွန်တော်တို့ရဲ့ professor ဆရာကြီးဒေါက်တာစိုးအောင်ကနေပြီးတော့ chairperson အဖြစ်တောင်းယူဆောင်ပြီးမှဖြစ်ပြီးတော့ speaker များအနေနဲ့ကတော့ကျွန်တော်တို့ရဲ့professor မတ်ဒေါခင်သိန်းမှုနဲ့ကျွန်တော်တို့ဒီ India မှာ foreign speaker ပေါ့နော်ဒေါက်တာပလန်ကီဆက်ပြဒေါက်တာထရီယာကနေပြီးတော့ကျွန်တော်တို့ဒီသက်ဆိုင်ရာ topic လေးတွေနဲ့ဟောပြောဆွေးနွေးပေးသွားမှာဖြစ်ပါတယ်ကျွန်တော်တို့ဒီပွဲလေးကိုပေါ့နော်မစခင်မှာကျွန်တော်ဒီပွဲလေးရဲ့ agenda လေးကိုကျွန်တော်အနေငယ်တင်ပြခြင်းပါတယ်ပထမဆုံးအနေနဲ့စီစဉ်တဲ့အရာကျွန်တော်တို့ရဲ့ Asia Frontier Market ရဲ့ကျွန်တော်တို့ Medical Therapy Lead တူဖြစ်တဲ့ဒေါက်တာယောဂက်ကနေပြီးတော့လာကွန်ပျူတာပေါ့နော်ကျွန်တော်တို့ welcome note အနေနဲ့ကျွန်တော်တို့စာပြီးတော့ပြောပြပြီးမှဖြစ်ပြီးတော့အစီအစဉ်နှစ်အရာဆရာကြီးကျွန်တော်တို့ရဲ့ဆရာကြီး Professor စိုးအောင်ကနေပြီးတော့contact setting and speaker protection အနေနဲ့ကျွန်တော်တို့ introduction လေးကိုစပြီးဖြစ်မှာပါတယ်ပြီးတော့အစီအစဉ်3ရတော့ကျွန်တော်တို့ Professor အမတ်ဒေါခင်သိန်းမှုကနေပြီးတော့ current management practice of HR positive FM breast cancer and challenges ဆိုတဲ့ခေါင်းစဉ်လေးနဲ့ကျွန်တော်တို့ပေါင်းဆွေးနွေးပေးတာဖြစ်ပြီးတော့စီစဉ်4ရတော့ကျွန်တော်တို့ရဲ့ India မှာ foreign speaker ဒေါက်တာပလန်ကီဆက်ရဒေါက်တာရီယာနေပြီးတော့ကျွန်တော်တို့ role of SCRD in the management of advanced breast cancer ဆိုတဲ့ခေါင်းစဉ်နဲ့ဆက်လက်ပြီးတော့ဆွေးနွေးပေးသွားမှာဖြစ်ပါတယ်ဒီကျွန်တော်တို့အစီအစဉ်လေးပြည့်ရဲ့အခါမှာတော့ကျွန်တော်တို့အစီအစဉ်9ရကျွန်တော်တို့ discussion တိုင်းလေးပေါ့နော် question answer session လေးကိုဆက်လက်ပြီးတော့ဆောင်းအောင်မှာဖြစ်ပြီးတော့စီစဉ်6အနေနဲ့ကတော့နောက်ဆုံးအနေနဲ့ပေါ့နော် CRU ဦးဆောင်အောင်နေပြီးတော့ကျွန်တော်တို့ဒီပွဲလေးရဲ့ပတ်သက်ပြီးတော့ conclusion remark လေးပေးတော့မှာဖြစ်ပါတယ်ဒါကြောင့်မလို့ကျွန်တော်တို့ဒီပွဲလေးကိုမစခင်မှာပေါ့နော်ပထမဆုံးအနေနဲ့ကျွန်တော်ဒီဒေါက်တာယောဂက်ချိုစပြီးတော့ဖိတ်ချင်ပါတယ် Dear Dr. Yogesh, may I cordially invited to welcome and please share the introduction speech. Thank you.
Thank you, Dr. Ong. A very good morning to all the delegates, to all the speakers, chairperson. I am Dr. Yogesh, and I would like to thank you on behalf of AstraZeneca and Mandla for joining this meeting on a Sunday morning and taking time out of your very busy schedule for this meeting. I'm sure this is going to be a great knowledge fest. We have a great expert speakers with us, and definitely it's going to be a great learning. Without taking much time, I would like to introduce today's chairperson, and from there I would request him to take forward the meeting ahead. So today's chairperson needs no introduction to the audience from Myanmar. He is Professor So Ong, who is a honorary professor, consultant medical oncologist, and president of Myanmar Oncology Society. He holds he is a fellow of the prestigious Royal College of Physicians in UK, and he holds an IT certificate degree from Cambridge, and also has obtained his medical oncology training from Tokyo, palliative care training from Calicut in India. So he has had a global exposure across. He's a member of British Oncological Association and an active member of ASCO and USA. So over to you, Professor Soong, for introduction of the other speakers and for setting up of context for today.
So first of all, I'd like to thank AstraZeneca, Dr. Yogesh, and our distinguished guest speaker, Dr. Trier, and our local speaker, Professor Kendemu, for coming to this event in person. Actually, this is a type of meeting which we have been longing for quite a long time. So we have been away from each other for more than 2 years because of this COVID and every other situation. So now things are coming back to normal, and we can meet again in person. Anyway, there are always pros and cons about these meetings. In-person meetings, you can have eye-to-eye contact, personal communication, which is really good for teaching purpose and communication purposes. On the other hand, if you have online meeting, you can sort of record all the meetings and re-listen at your leisure anytime you like. So So if you go to big meetings like ESCO and ESMO, there are so many sessions running in parallel at the same time, and you can't attend all the sessions. But if you join online, you can record many sessions at the same time and listen back at leisure. So there are always pros and cons, but I prefer personal meetings more. And anyway, we have to strike a balance between in-person meeting and online meeting. So first of all, I would like to introduce the first speaker, Professor Kendemu. He's a senior medical oncologist, and he got MBBS in 1994 and MSc medical oncology in 2002. And he also got MRCP in 2015 and FRCP in 2020. And she also had other study awards like palliative care trainee in Singapore in 2017, and also Australian Award Fellow in 2013. And also cancer registry trainee in Myanmar and I think in India as well. So he has a lot of experience, not only in medical oncology field, but also in cancer registry and palliative care field as well. And the second speaker, Dr. Detria is a Director and Chief of Medical Oncology Services from Renova Hospital and Secunderabad. And he is an expert in many cancer types in the field of oncology, including gastrointestinal cancer, thoracic cancer, bone and soft tissue cancer, genitourinary cancer, hematologic cancer, head and neck cancer, breast cancer, pediatric cancer, and skin cancer, etc. And he has worked at Indo-American Cancer Institute and Research Center, Hyderabad, where he worked as a consulting medical oncologist and completed 3 years of residency at Gujarat Cancer Institute and Research Cancer Center. And he also received his MD in pediatrics from Anisha Municipal Medical College and SET KM School of Postgraduate Medicine and Research, Ahmedabad. And then he did his GM at Gujarat Cancer and Research Institute, Ahmedabad, and he received gold medal there. And he presented more than 75 lectures on various aspects of oncology across various national and international forums. And he also did PhD thesis on clinical and pathological profile of extranodal lymphomas. And he was awarded Best Project of the Year. And he has made multiple publications in internationally reputed journals, and he is also involved as investigator in multiple international clinical trials. And he was also a delegate at the International Health Congress, Health Walls Asia Conference in Singapore, where he presented 2 posters, including the data on cetuximab at IACI-RC, and an interesting case report of chronic myeloid leukemia. So after introducing these 2 speakers, I'll make some introductory remarks and set the scenes for the 2 speakers. And according to Globocan 2020 data, breast cancer is the second most common female malignancy after cervical cancer in our country. And like in many other LMICs, breast cancer is not only common, but also the patients tend to present late in stages. This has huge implications in terms of biological as well as financial burdens, not only for each and every individual patient, but also for the country as a whole. And this is especially the case where there is no security, social security support or insurance systems in the country. So we doctors are responsible to give the best possible treatment for each and every patient within their financial capacity and within their biological tolerability. And in this era of personalized and also expensive medicine, it is very important to give the right treatment to the right patients. And if you fail to give the most appropriate treatment, especially at this time of expensive medicine, you will not only be doing harm to the patients, but you will also be throwing patients' money away down the drain. It's very important not to waste money. You must have justice. And according to the action study data from Myanmar, so we had the action study data, and in this study, it was conducted between 2013, 2012, and 13, and it was published somewhere about 2015 and 16. Our country participated in that study, and we contributed about 9,000, nearly 10,000 patients from our country from 6 cancer centers. So final outcome, final results said that in our country, 1 year after the diagnosis of cancer, 29% of cancer patients had died already. And 48% had financial catastrophe. And financial catastrophe is defined as out-of-pocket medical costs exceeding 30% of annual household income. And in a country, almost every penny is out of patient's pocket. And we do have some contribution from the government from time to time, depending on the mood. And just 23% were alive with no financial catastrophe 1 year after diagnosis. And cancer-induced economic hardship, which is defined as inability to make necessary household payments, it is evidenced in 1/3 of patients. And 5% of patients were pushed into poverty. Poverty means living on less than $2 a day. And 28% resorted to taking personal loans. So many patients and their families are left either after being the treatment completed or whatever have been being poor. So these data, although it was published about 5 to 6 years ago, they are still valid and they are still true until today. So it is very important. It is high time that we did something to reverse this situation in Myanmar. So we need help from every angle. We need every helping hand. And as you all know, there are different, when it comes to breast cancer, which is the second most common cancer in our country, as you all know, there are different types of breast cancer that require different unique treatment strategies. And depending on the HR and HER2 status, there are 3 main categories, namely, number 1, HER2 HR positive and HER2 negative disease. Number 2, HER2 positive disease, and number 3, triple negative disease. So to give the right treatment, it is extremely important to get reliable and quality, repeat, reliable and quality laboratory results for ERP and HER2 status. And to be honest, we can't do these 3 tests even for each and every patient in our country. Many patients are poor. There are many patients are living hand to mouth, day in and day out. So they can't afford these sort of things, let alone high-end NGS and HRD analysis, etc. So anyway, there are a few chunk of patients in our country which can afford anything. You just name it, they are very rich. So there is a huge gap between the poor and the rich. So we need to close that gap as much as possible. And so in this context, it will not be an overstatement to say that it is the pathologist who actually dictates the right treatment for the patients. So we can categorize HR, now coming back to HR positive, HER2 negative patients, we can broadly categorize into early non-metastatic stage and late and advanced metastatic stage. And the goal of treatment in non-metastatic setting is to reduce the risk of development of local recurrence and distant metastasis. And the goal of treatment in metastatic setting is to make the disease a chronic one with which the patient can live long with a good quality of life. And in other words, to improve disease-free survival and overall survival with good quality of life. Quality of life is very important. In early non-metastatic stage, if we can afford, if the patient can afford, we can do risk stratification by gene expression analysis, which are very, very expensive. Only very few patients can afford in our country. And we can, if we can do that, we can sort of de-escalate the chemotherapy treatment, and we can resort to non-chemo agents like hormonal therapy and CDK4/6 inhibitor, etc. And another strategy to avoid chemotherapy is to do ovarian suppression in premenopausal women, followed by AI. I'm sure Kandimu will elaborate on this. And in metastatic setting and advanced setting, chemotherapy can be used if the patient has visceral crisis, symptomatic visceral crisis, and otherwise there are many chemo-free agents, chemo-free strategies which are available for use nowadays. And like there are CDK4/6 inhibitors that can partner with endocrine therapy in both premenopausal and postmenopausal patients, and in both metastatic and non-metastatic settings, and improve the outcome of the patients. And the currently approved CDK4/6 inhibitors are palbociclib, ribociclib, and abemaciclib. The problem is the price, money talks. So another thing is these agents, CDK4/6 inhibitor, they are supposed to give on a long-term basis, at least optimally 2 years. So it is very expensive. And another agent, very good agent, fulvestrant, SERD. This is the only agent injection form available in the field of SERD at the moment. It's very useful and effective. Selective estrogen receptor degrader or downregulator. It can partner with any SCRM, tamoxifen or AI, and there are oral forms of SERD being developed nowadays, like elacestrant, amcinestrant, and giredestrant. They are being developed, and if they are approved, I'm sure they will be very, very useful for those patients who are endocrine resistant, especially in those patients with ESR1 mutations. And in advanced setting, one can also do HRD tests and BRCA1/2, including BRCA1/2 as well. And if the patient is BRCA1/2 mutation positive, we can also use PARP inhibitors together with endocrine therapy. And another important thing is nowadays we can classify not only HR positive patients, we can also classify HER2 positive patients. We can also classify HER2 low patients. Previously, HER2 0, HER2 1 plus negative, HER2 2 plus borderline, and ISH positive, it is positive. If ISH negative, it is negative. But nowadays, we call these patients HER2 0, 1, 2 plus ISH negative, HER2 low patients. So we can sort of recategorize the breast cancer. And we should call it HR positive, HER2 low patients. Why? Because there are more stronger anti-HER2 agents being developed, like trastuzumab deruxtecan, which is more potent than DDM1. It's now being used in HER2 low patients. And what we call HR positive, HER2 negative patients, this trastuzumab deruxtecan is being used, like in Destiny Breast 04 studies, and there are many other studies as well. And they are quite useful and quite successful. And another agents for advanced HER2 positive, HR negative patients is sacituzumab govitecan. This is ADC, antibody drug conjugates, and the TROP2 agents. And additional therapies are also available depending on the biomarker for advanced diseases, such as alpelisib for PIK3CA mutation, and Oracert for ESR1 mutation, like I said before, and also lorlatinib and entrectinib for NTRK mutations. And PARP inhibitor can also be used for those patients with PALB2 mutations, and Badasatinib and Capdivasatinib for AKT1 mutation, etc. And there are also immunotherapies for MSH high and deficient MMR patients, and also patients with tumor mutation burden greater than 10. And there is also drugs for red fusion approved by FDA, that is selpercatinib. There are many agents. The only thing is they are very expensive. So in our country, they are out of questions at the moment. But anyway, like I said before, there are many patients who can, there are very few patients who can afford. So what we need to do is we have to keep our knowledge up to date. For the majority of patients, we must be able to provide the best treatment within their capacity, financial and biological capacity, and with whatever agents available. And for those who can afford, so we must be able to advise the best possible treatment for them so that they can get whatever available, if not in our country, from any country abroad, like India, Thailand, and Singapore. So we have dual responsibility, do the best for our majority of patients and keep our knowledge up to date to advise for the best treatment for those who can afford anything. So if you look at the NCCN guidelines, there are 4 types of guidelines, 1 full guidelines. The other 3 are basic, core, and enhanced. Actually, 4 guidelines are applicable in any country. Why? Because these guidelines are not applicable across the country, for example, for Myanmar. Myanmar being LMIC, you can see that everybody is poor. There are many rich patients, as you all know. So we must be able to advise full therapy, the best treatment for them. Nothing to do with politics. This is health issue. And other new agents are androgen receptor modulator, enabosum, which is being tested at the moment. Those patients with ER positive, androgen receptor positive, or positive breast cancer as well. So it has not been approved yet. And another interesting agent is anti-BCL2, which we use in lymphoma, that is venetoclax. So in breast cancer, ER-positive breast cancer, 80% of patients have this BCL2 mutations. And there is one phase 2 trial, Veronica, which compare fulvestrant plus venetoclax versus fulvestrant plus placebo in those patients with hormone receptor positive and HER2 negative patients. But at the moment, this study is negative study. It is still ongoing, and we will see the results, final results in the long run. So with this, I'll conclude my introductory remarks, which is a bit long, and I'll call upon the next speaker, and it's Dr. Kendemu, to give her talk on ER-positive advanced breast cancer.
Thank you, CIG, for kind presentation. And good morning, Mr. Chairperson, CIG, and distinguished guests, and my senior and junior colleague. And today I would like to talk few words about advanced breast cancer with a hormone positive setting. Actually, it is a very broad area, and I can only touch a small percentage of that area. And I would like to learn from my senior teachers and as well as from the orange speaker. And I would like to start with my objective. My objective to be discussed today is a risk factor for the breast cancer, hormonal treatment for the advanced breast cancer, and ESMO guideline, very simple ESMO guideline for advanced breast cancer, and fulvestrant mechanism of action and clinical data, and resistant to endocrine therapy, and mostly on the ESR1 mutations. As we all know, risk factor for the breast cancer is related to the advancing age. It is a significant risk factor for breast cancer, and lifestyle is of course very important. Adult weight gain, sedentary lifestyle, alcohol consumption, high fat diet lead to high estrogen level and lead to increase the risk of the breast cancer. Family history of the cancer, in fact, relative and personal history is also important. And genetic predispositions such as mutation in the BRCA1 and BRCA2 are also important. And exposure to young age with the ionizing radiation is also a significant factor. And a condition where high estrogen exposure to a lady with a reproductive history of early menarche, less than 12 years, and late menopause, more than 55 years, and a late age of first-term pregnancy, more than 35 years, and nulliparity are important factors. And of course, recent use of HRT and recent use of estrogen-containing OCP is also a significant factor. SAIG has elaborated that breast cancer is not one disease. Using the gene expressing profiling, breast cancer is divided into the lumina A and lumina B and HER2 positive and basal-like subtype or triple negative breast cancer. Again, lumina A is, we also know, we have already known that ER and BR positive and HER2 negative and Ki67 is low. But in the lumina B, there are two types, HER2 negative and HER2 positive. Ki in the lumina B, one subtype is Ki67 high. In the basaloid type or triple negative breast cancer, BRCA1 mutation and P53 mutation are important. How about chemotherapy versus endocrine therapy? And nowadays we consider optimal management and optimal benefit with the less toxicity effect to our patient. We should emphasize on whether we should start with the endocrine therapy, we should put on endocrine therapy or start the chemotherapy straight away. Now, endocrine therapy is a preferred option for hormone receptor positive disease, even in the presence of visceral disease, unless there is visceral crisis. So I would like to elaborate again that visceral crisis is defined as severe organ damage as assessed by signs and symptoms, laboratory studies, and rapid progression of the disease. Endocrine therapy alone or in combination with targeted agent is generally less toxic than the chemotherapy, but CIG have already mentioned that it has a financial toxicity. It is preferable for most patients with hormone receptor positive disease to begin treatment with endocrine therapy. But chemotherapy is reserved for patients with a refractory to endocrine therapy, first line or second line, or with the patient with a visceral crisis. This diagram shows the hormonal therapy in advanced breast cancer based on the menopausal status. And depending upon the menopausal status, premenopausal women and postmenopausal women. Premenopausal women, we do ovarian ablation or ovarian suppression and combination with endocrine therapy with the targeted agent. With the endocrine therapy, we use tamoxifen or aromatase inhibitor, but tamoxifen is preferable in premenopausal women. And with the targeted therapy, CDK4/6 inhibitor like the palbociclib and ribociclib. And we can use ovarian suppression or ablation in combination with endocrine therapy alone. Or if resource is limited, we can use tamoxifen alone. And let's look up about the postmenopausal women. First choice is the aromatase inhibitor plus targeted therapy to the CDK4/6 inhibitor. Aromatase inhibitor in first line is letrozole plus CDK4/6 inhibitor palbociclib, ribociclib, or abemaciclib. Another one is fabrazyme SCRT, can be useful as a alone or combination with the CDK4/6 inhibitor is also helpful. As like AI, fabrazyme can be given combined with the palbociclib, ribociclib, and abemaciclib. Another thing is fabrazyme plus abelacib, which is a PIK3CA mutation inhibitor, is useful nowadays, as in endocrine refractory cases with the ESR1 mutation cases. This diagram show the hormonal therapy for advanced cancer milestone. The hormonal therapy we have already know in our oncology field that hormone is an important factor for the breast cancer. In the 19th century, late 19th century, start with the oophorectomy and response to they recognized that there was a response to advanced disease by George Benson. In the mid of the 20th century, breast cancer is mainly produced by high estrogen level. In 1977, ER identified and so tamoxifen was approved as hormonal therapy. In the 90s, immunohistochemistry, IC is developed in pathology field. They are just elaborated that pathology is the most important subject but to give optimal management. And for ER and BR analysis, in 1999, first selective AI and approved for the advanced breast cancer. In 2002, ER downregulator was approved and AI approved as adjuvant therapy. In 2010, anti-HER2 plus AI approved for the ER and HER2 positive advanced cancer. In 2012, mTOR inhibitor plus AI was approved. In 2015, CDK4/6 inhibitor together with the AI is approved as the first line therapy as an endocrine management. These are the agent of the endocrine therapy for hormone positive, HER2 negative advanced breast cancer. It is just for our young colleagues. They are divided into SERM, SERDS, LHRA and agonist, aromatase inhibitor, non-steroidal, steroidal, and progestin, nebulized steroids, and estrogens. It is a little bit busy slide. It is adopted from a 2020 ESMO guideline. We are discussing about the advanced breast cancer. There are two types of advanced cancer: locally advanced and late advanced cancer. In the locally advanced, and we can straightly go to the surgery, but some of the cases cannot be operable. So we start with the systemic therapy. Initial therapy depends upon the tumor and patient characteristic. If patient is hormone positive and HER2 negative, we divide it into the non-inflammatory and inflammatory. Non-inflammatory cases, we can give either endocrine therapy, or in the advanced stage, we can give a chemotherapy. In the inflammatory disease, we use chemotherapy. If tumor remain inoperable, further systemic therapy should be considered. And if not, and tumor remain inoperable, treat as an advanced breast cancer. If we have a successful story with the endocrine therapy or either chemotherapy, operable tumor, and we do mastectomy with axillary dissection. In some cases with the breast cancer therapy, in the young woman with a small tumor, we can serve the breast cancer therapy. In inflammatory disease, we can do a mastectomy with the axillary dissection. If previously not given with the RD, we can offer radiation therapy. If tumor remain inoperative and HER2 positive, and we treat as an advanced breast cancer. After the radiotherapy treatment, if patient is HER2 positive, we continue the anti-HER2 therapy at least 1 year. If HER2 positive, and start and continue endocrine therapy for at least 5 years. It's also a busy slide, but to show how to do with the hormonal therapy. It is for the first line hormonal therapy in the advanced hormone positive and HER2 negative advanced cancer. We can use either endocrine therapy or chemotherapy. As I have already mentioned, chemotherapy is useful only for the visceral crisis or without further endocrine therapy option. In the endocrine therapy option, the preferred treatment option divided into the pre-menopausal, perimenopausal, and post-menopausal. In the pre-menopausal and perimenopausal women, we should do the ovarian ablation or suppression. And then next step is same as both menopause women. First line we can use the aromatase inhibitor, either letrozole or anastrozole plus CDK4/6 inhibitor. If more than 12 months since AI, or we can use 5% plus CDK4/6 inhibitor. And at the same time, we should check for the PARP inhibitor and BRCA mutation for further management plan. If CDK4/6 inhibitor is not available or in selected cases where not needed, we can still use the tamoxifen, 5% or AI. If AI or CDK4/6 inhibitor is resistant, it is we can use a second line and beyond. It is a PIK3CA mutation. We should test for it, and if it's a wild type, we can use a different endocrine therapy together with CDK4/6 inhibitor. But in the big 3CA mutation cases, 4% plus abemaciclib is a very useful drug nowadays. For the chemotherapy, we can use sequential single agent chemotherapy. The most common chemotherapy useful are in the blue box with the anthracycline or taxane, capecitabine, eribulin, or vinorelbine. And this is just for the knowledge sharing. It is how to get a diagnosis, staging, and treatment of the metastatic breast cancer. And if diseases are more than 2 years or newly diagnosed metastatic breast cancer or recurrent breast cancer, we should biopsy for the metastatic lesion to confirm the diagnosis, and then reassess for the biomarker ERBI and HER2. And then, of course, triple negative breast cancer, we should do the PD-L1 mutation and BRCA mutation for the PARP inhibitor. In patients with the hormone-resistant tumor, we should do PIK3CA mutation status and germline mutation for further assessment. And then we have to do staging workup, history, physical examination as before, hematology, biochemistry, tumor marker, and imaging of the chest and abdomen, and PET-CT. In the symptom management, we should do the brain imaging. It is just for the information for my junior colleague. Now, I would like to share some short video clip about how breast cancer is produced and breast cancer signaling is done. Let me show that.
Estradiol circulates throughout the body in the vascular circulation and freely diffuses through the plasma membrane of the cell. Estrogen interacts with the estrogen receptor in the plasma membrane, cytoplasm, and nucleus. Once estrogen binds to the estrogen receptor, it interacts with the large heat shock protein known as HSP90. HSP90 dissociates, allowing for the ER to undergo a conformational change and dimerization, leading to the activation of specific transcriptional sites on the receptor. Both activating function AF1 and AF2 are activated on the ER. The dimerization ER then translocates into the nucleus and binds to the estrogen response element, or ERE, of DNA. Co-activators and other transcription factors are recruited to the site, leading to this transcription of several estrogen-sensitive growth-promoting associated genes via RNA polymerase. This causes further cancer cell division. Therapies that inhibit estrogen-estrogen receptor interactions can inhibit tumor growth.
And I would like to share screen with another video and mechanism of action of 5%. No, not.
Estradiol circulates throughout the body.
Not a good, not a good. No, not. Yes.
Fulvestrant is an estrogen receptor antagonist and competes with greater affinity than estrogen for estrogen receptor binding on the binding site. When it binds to the estrogen receptor, the receptor changes shape. The transcription sites AF1 and AF2 remain disrupted and inactive, and only few dimers form. Fulvestrant binding leads to unstable complexes, which leads to accelerated degradation of the ER, thus reducing its availability for estrogen binding. While some dimers are recruited to the estrogen responsive element of the DNA, no co-activators are recruited, and thus no transcription of the estrogen responsive genes occurs. This leads to complete inhibition of estrogen signaling through the ER and slows the cell proliferation rate, ultimately causing cell death.
Okay, and I would like to. There's many trial of 5% trial in patient with breast cancer, but I would like to elaborate only 3 trials. One is a confirmation study, and which demonstrate which number of which amount of 5% is significantly improve the progression-free survival. It is called the FAM-DI Leo et al. In 2010 and 2014. It is a phase 3 trial, and total 700 patients are randomized into the 4%, 500, and 250 milligram. It's a treatment is a second line, and the primary endpoint is a DDP. In clinical benefit rate is 45 versus in the versus with the 500 milligram of Fulvestrant, and overall with the 39.6 with the 250 milligram of Fulvestrant. And again, with the progression-free survival, and 500 milligram of Fulvestrant is 6.5 versus 250 5.5. P-value is 0.06 and significant. Another trial is a first trial. It is done on 2009, 12, and 2015. It was a phase 2 trial done in the 205 people of postmenopausal women are randomized into the 2 group, 5% 500 milligram or anastrozole 1 milligram as a first line setting. Primary endpoint is a CVR. In the CVR, we found that in the 5% has a CVR for 72.5 versus, and for the anastrozole 67.0%. P-value is only 0.38. Regarding the progression-free survival, it is 37.4 in a 5% and 13.1 in the anastrozole M, with the p-value 0.01, which is significant. Another study I would like to show is a Falcon study. It's a phase 3 trial. It is done in the 462 women with the postmenopausal status, given either 4% 500 or anastrozole as first line therapy. Again, the progression-free survival has a 16.6 with the 5% and compared with the anastrozole alone 13.8 and the p-value 0.04. Now, another study is a Paloma study. In the Paloma 3 study, conducted at the 2015 and 2016, and that study about the 5% in combination with the targeted agent, 5% plus CDK inhibitor. In the phase 3 study, is done for pre-menopausal, perimenopausal, and postmenopausal women. And N is 521 is randomized into two groups and as a second line therapy, 5% 500 milligram plus CDK4/6 inhibitor and 5% 500 milligram plus placebo. In the progression-free survival, stated that in the 5% plus targeted therapy, it has 9.5 versus 4.6 in only 5% M. P-value is less than 0.001, which is significant. And this study also show significant of both menopausal women with the hormone receptor status randomized into the two groups, 5% and anastrozole. As previously mentioned, 5% M has a better progression-free survival in 16.6 compared with anastrozole 13.8 months. And how about with the visceral disease? Visceral disease, if visceral disease is without the visceral disease, 5% has a median progression-free survival, 22.3 months compared with the anastrozole 13.8 months, and which is a very interesting one. But with the visceral disease, there is no changes with the 5% M and anastrozole M. And median progression-free survival is 13.8 and 15.9. And regarding the adverse event, 5% major side effect is arthralgia, which occur in 17% of the patient. Another is the altered liver function test, which is an important one, and also with the hypertension, we should consider when we treat with the 5% management. Others are hot flashes, fatigue, and nausea, back pain, diarrhea, and anemia and dyspnea, and peripheral edema. And let me move to the resistance to the endocrine therapy, ESR1 mutation. One of the resistant mechanisms to endocrine therapy is ESR1 mutation. ESR1 mutation occurs rarely in primary breast cancer. High prevalence in post AI advanced breast cancer, implying evolving through selective treatment pressure. ESR1 mutation accounts in 20% of patients with ER positive metastatic disease. ESR1 mutation occur in hotspot region in ligand bind domain of estrogen receptor, resulting in ligand-independent constitutive ER activity. A patient with the ESR1 mutation have shown poor progression-free survival on subsequent AI-based therapy, and some sensitivity showed to the tamoxifen and 5% reported, although higher doses required to inhibit the ESR1 mutation. And this is a SOPHIA study that's compared the extramethasone versus 5%. In this cases, we look for the ESR1 mutant patient and ESR1 wild type patient. It is randomized into the two groups and give an extramethasone and the 5% containing regimen. In ESR1 mutant patient, extramethasone produce median progression-free survival about 2.6 months compared with the 5% containing regimen. Progression-free survival is higher with the 5.7 months. But compared to the wild type, there is no difference in extramethasone group and 5% containing regimen. So 5% is highly effective in ESR1 mutant patient. So let me go to the summary. And breast cancer is one of the most common cancer in the perimenopausal and postmenopausal women in our country. In our country, we diagnose the patient in most of the advanced stage. And endocrine therapy is preferred option for hormone receptor positive disease unless there is visceral crisis. SERDS and FASLO test of 5% inhibit the both estrogen dependent ERFR and estrogen independent signaling. That dual mechanism of action with the Faberson explained the delay in resistance mechanism. Faberson of Isotest is indicated for the treatment of estrogen receptor positive, locally advanced or metastatic breast cancer in postmenopausal women not previously treated with the endocrine therapy or with a disease relapse or on or after adjuvant anti-estrogen therapy or disease progression on anti-estrogen therapy. So let me conclude my presentation. Thank you for kind attention.
Thank you, Professor Kindemu, for very comprehensive presentations. We'll have the Q&A session at the end of both lectures. So may I now call upon Dr. Dedet Trier for his talk on CERT. So I'm sure we'll hear a lot of invaluable information from Dr. Dedet Trier.
Shall I talk like this? Yeah, a point. So,
Yeah, this one. Is there any video in it?
no video. Thank you so much, sir. At the outset, I would like to inform you all that the pride, the pleasure, the privilege, and the prestige to be a part of this August gathering of my oncology colleagues in this beautiful country is entirely mine. A very good morning to all of you, and I'm here to talk about the role of selective estrogen receptor down regulators, specifically focusing on fulvestrant or Faslodex in the management of ABC or advanced breast cancer. Our chairperson, Sir Professor Seo Yong, gave a clear idea about the challenges we face here, and to a large extent, a significant proportion of what he spoke also applies to a large proportion of our patients in our country too. In addition, Professor Kim Ting Moo gave a clear picture about the idea of how Faslodex, fulvestrant, or the estrogen receptor, all of them, and the two videos gave a clear view about how the ER is, what the ER structure is, what the ER function is, and how Faslodex or fulvestrant is able to degrade the estrogen receptor. My introduction is, as you all know, 65 to 75% of our breast cancer patients are ER and PR positive or ER positive. So it's HR positive and HER2 negative breast cancer comprising almost 2/3 and sometimes 3/4 of a patient population. Excuse me. Yeah, I'll just need him once. So it's important to know patient profiling. And that's, I think, is the first thing we do when we treat our patients of, can this go?
So you want to put.
Yes. So it's important to profile our patients when a patient of advanced breast cancer or MBC comes to us. The first is, of course, to look at the ER/PR status and possibly also utilize the block for HER2 new status and Ki61 status. I think these four are compulsory: ER, PR, HER2 new, and Ki67. Some among us may also want to check the PIK3 mutation state as a baseline so that you can decide the second line treatment afterwards. The PIK3CA mutation is not a dynamic biomarker. It is a stable biomarker. So if it's a PIK3CA mutant today, that tumor almost always remains PIK3CA mutant afterwards also. And approximately 30 to 40% of patients might be having a PIK3CA mutation. And again, as Madam rightly mentioned, around hardly 3% of patients might be having a ESR1 mutation at baseline. but that number swells to almost 40% when disease progression happens after a first-line endocrine therapy, say for instance, usage of an aromatase inhibitor-based therapy. So ER, PR, HER2/neu, Ki67, yes, maybe PIK3CA mutation and maybe ESR1 mutation. Next, is the disease de novo metastatic, or has it recurred back in a patient who already has breast cancer? And so what was the previous treatments the patient received? Endocrine therapy? Was it tamoxifen? Was it an AI? Or was it now with the recent data coming up, an AI plus abemaciclib, for instance? And also, what was the disease-free interval? How long after the adjuvant treatment the disease came back? Or it came back on the adjuvant treatment in the first 2 years or after the first 2 years. Number 3, does the patient have visceral metastasis or not? Number 4, is the patient symptomatic or not? And symptomatic, how severe are the symptoms? And are there some lab abnormalities? Is the liver function test altered? Is the kidney function test altered? If the patient has lung metastasis, then is the pulmonary function test altered? So, presence of symptoms, symptomatic or asymptomatic, and how severe are they? Is the patient by chance in a visceral crisis? The adverse events of your treatment, which you now plan to give to the patient. Patient factors and preferences. That I think is most important and least discussed. It's almost always a physician preference. And we trying to tell the patient that this is my choice, which we should. But then we should also listen to the patient and see what his preferences could be, discuss the data, try to give them time to be with us in the treatment journey of fighting the disease. And lastly, again, this happens in our country too, with me as well. Can the patient afford the drug? Does the patient have an insurance? And if so, what are the co-pays? So I think these 7 factors are very, very important when you profile your patient before you start your patient on an individualized choice of therapy, so that you decide the choice of treatment for your patient in front of you rather than generalize it to the entire patient population of HR positive, HER2 negative, advanced breast cancer or metastatic breast cancer. So do look at the entire patient profile before you embark upon a treatment decision for your patient. There have been some breakthroughs in HR positive, HER2 negative breast cancer all the way from 1977, tamoxifen, to the current era. And the future may be looking at oral SERDs. The initial data with the oral SERDs has been slightly conflicting, and therefore I think fulvestrant would be the SERD which is here and is there to stay for a pretty long time. I have showed in some red blocks the FDA approvals of these treatments, especially fulvestrant as single agent, fulvestrant with a CDK4/6 inhibitor like say palbociclib or abemaciclib, or fulvestrant along with a drug by name alpelisib, which targets the PIK3CA mutation breast cancer cells. So fulvestrant alone, number 1. Number 2, fulvestrant plus a CDK4/6 inhibitor. And number 3, fulvestrant plus alpelisib. And these are the timelines when the breakthroughs happened. I'll divide my talk into 6 sections, and at the 8 sections, and at the end of it, give you 8 important take-home messages. Number 1, the structure of the ER was so beautifully presented in the video by the previous elegant speaker. It has 3 domains, AF1, which is in the N-terminal, the amino terminal, and then the DNA binding domain in the center, and to your left is AF2, which is the ligand-dependent activation function 2. So why is AF2 important? It's because estrogen binds to the ER on the AF2. So that's how the first line treatments, drugs like say AIs, etc., work, because they are not allowing the estrogen to reach, because you're depleting the estrogen. But when progression happens, mutations happen in the AF2 domain. And therefore, the AF1 is ligand independent. But fulvestrant works whether it is ligand dependent or ligand independent. So AF1 or AF2 doesn't make a difference because you are degrading the estrogen receptor. Now, that's not the case with either tamoxifen or with anastrozole, letrozole, exemestane. There, you are looking at only the AF2 domain. And the video also showed about the heat shock protein 90, HSP90, which is keeping the ER in an inactive state, in an inactive conformational state. And when estrogen, the ligand, comes and binds to AF2, which is the ligand dependent activation factor 1 domain, then dimerization happens, HSP90 separated, and the nuclear translocation happens. So the ER is basically found on the cell membrane or the cytoplasm or the nucleus. It is a cytoplasmic receptor. It is found in the cytosol, but it has to work in the nucleus. It has to translocate to the nucleus. And then the estrogen response element in the DNA will take it forward. So we have the N-terminal domain, AF1, which is ligand independent. Then the DNA binding domain binding to the estrogen response element. And finally, the C-terminal is the AF2. Now, several approaches exist for inhibiting ER signaling through endocrine therapy. Number one, this is the mainstay of treatment. We have now realized that hardly any patient of ER positive, HER2 negative advanced breast cancer will receive chemotherapy. It has to be almost always a first line endocrine therapy, and that can be deprive the estrogen, for instance, by using the AIs, anastrozole, letrozole, or exemestane. So that is deprive the estrogens. Number two, directly inhibit the estrogen receptor by using SERMs, selective estrogen receptor modulators. These drugs have mixed agonist and antagonist action. And the classical example is tamoxifen. Lastly is degrade the estrogen receptor. So now it's AF1 or AF2, ligand binding or not binding makes no difference. You degrade the receptor by using a selective estrogen receptor degrader or SERT. And the classical example is fulvestrant. So it targets the ER, which is a critical driver of tumor cell proliferation. One mechanism, but ultimately 5 elements. Key 5 elements. Number one, it binds to the ER competitively and does not have any known agonist effect. Unlike tamoxifen, which is a mixed agonist-antagonist, here there are no agonistic effects. So it's a estrogen receptor competitive binder. Number two, it blocks the functions of the ER. Activation does not happen. Dimerization does not happen. It doesn't allow it to translocate to the nucleus also. So it doesn't allow it to reach the endocrine responsive element on the DNA. So it's a competitive binder and it's a blocker. Thirdly, it degrades by accelerating the loss. So it's an estrogen receptor degrader. Fourthly, it inhibits the growth of cells which have been exposed to tamoxifen in cell lines. So tamoxifen resistant cell lines also have been shown to respond to fulvestrant. That's because it's degrading the receptor straight away. And lastly, that leads to a decrease in Ki67. When you follow up these patients and do serial biopsies, you find that MIB1, a marker of tumor cell proliferation, Ki67, the labeling index, successively comes down. So this is how this drug has 5 key elements. It's a binder, it's a blocker, it's a degrader. It can work even if tamoxifen fails, and it decreases the Ki-67 labeling index. So 5 key elements of fulvestrant. Faslodex is fulvestrant. So that's my first take-home message for all of you. Fulvestrant we discussed, and Faslodex is fulvestrant. Section 2 of my talk will focus about 2 studies, studies 20 and 21, which looked at an AI anastrozole Arimidex compared to fulvestrant Faslodex at 250 milligrams. So you're given 250 mg of Faslodex once every 28 days. And both the studies were pivotal trials. Study 20 was in Europe, Australia, and South Africa. And study 21 was performed in North America. And these 2 trials, after the patient failed prior endocrine therapy, you this is a trial which is, I'm talking in 2000s, almost 20 years back. So almost always these patients got tamoxifen. So prior endocrine therapy had failed, and now you put them to fulvestrant, a pure anti-estrogen, 250 mg IM monthly, and compare that to Arimidex 1 mg orally daily. The primary endpoint was time to treatment progression. And Faslodex was as effective as anastrozole in terms of TTP. The primary endpoint in both the studies across separate continents, Faslodex 250 mg IM is as effective as anastrozole, or at least as effective as anastrozole. And the difference numerically is there, 1.4 month advantage of Faslodex over Arimidex. But the hazard ratio is 0.95. Hardly any advantage. The 95% CI, as you see, there is crossing 1 point, crossing 1. So once it crosses 1, then there's hardly any difference. And the p-value, as you know, should be at least less than 0.05. It was 0.48. When you compare 2 drugs, you look at 4 things. What is the absolute difference between the 2 drugs? And that's 1.4 months here. But is it significant statistically? It's not significant here. Number 2, what is the hazard ratio? I think it should be, for us to accept the drug, at least hazard ratio of 0.80 or less is acceptable to us for using the drug. Even 0.85 is fine. It's 0.95. And then the 95% CI lastly should not cross unity. And so as you can see, the hazard ratio is 0.95. No. The 95% CI is 1.10. No. And lastly, p-value is 0.48. So Faslodex versus Arimidex, both are equal. And the key conclusion, in the overall survival also, you did find essentially no difference. But it was this which led them to approve the drug in 2002, because it was as effective as Arimidex. For example, a patient has, with anastrozole, a lot of side effects after the first 10 days or 14 days. What do? You have not, tamoxifen has been used, and AI after 15 days with arthralgias. You can always think of using fulvestrant at 250 mg, and that was the intention. Why in 2002 in US and 2004 in EU, the Faslodex got approved dose of 250 mg every 28 days. So it's as effective as anastrozole, and possibly adverse events were equal between both the arms. So take home message 2. AI anastrozole versus fulvestrant 250 mg, 2 pivotal trials, study 20 and study 21, done across 4 continents, 4 key regions, clearly tell that Faslodex is as effective as anastrozole or Arimidex. So AI versus fulvestrant 250 mg, both are equal. Now we come to section 3 of my talk. And we'll talk about a study which already Madam alluded to. The first study. You take 200 patients, randomize them 1-to-1. First line postmenopausal patients, ER and or PR positive advanced breast cancer. Same trial design, anastrozole 1 mg per day as first line, but the dose of fulvestrant is to use a loading dose. So 500 mg on day 1, day 15 and day 29, or day 0, day 14, day 28, and then continue at 500 mg every 28 days. So it's not 250 mg every 4 weeks, it's 500 mg, the dose is doubled, and then you're giving a loading dose of, in the first month, 3 doses. And you have key points and data cutoff happened. January 2009 was the primary analysis. March 2010 was the update in TNB, and then finally the final OS analysis. So a robust trial followed up appropriately over many years and was published in the JCO in 2009. The primary objective was to show, is there an OS advantage? Now you find not an improvement in response rate or PFS. When you increase the dose of fulvestrant, you find an advantage in overall survival. With anastrozole 48.4 months, with fulvestrant 54.1 months. We as oncologists want a clinical trial if it's able to show an advantage in overall survival. So fulvestrant at this schedule gives you a 6-month advantage in absolute numbers. For 4 years, 48.4 months with anastrozole becomes 54.1 months. So absolute difference is there. Number 2, hazard ratio of 0.70. 30% reduction in the risk of death when you choose fulvestrant over anastrozole, and the p-value is significant. So all the 3 features and the 4 features have been met. What this trial also showed was, in those patients who had not received any form of endocrine therapy in the past, these were the patients who benefited the most. So in those patients who have not received prior endocrine therapy, for example, adjuvant tamoxifen not taken, then you find fulvestrant versus anastrozole, the advantage is maximal. They tried to look at this in the second study because this subgroup data told them that this might be the patient population to benefit most from Faslodex versus anastrozole. And so came the Falcon study. So the first study was a precursor to the Falcon study because the subgroup data told you that if your patient has not received prior endocrine therapy, so endocrine treatment naive patients benefit the most by using Faslodex. So you look at 450 patients who are ER positive, HER2 negative, LABC but surgery not feasible, or MBC, up to 1 line of chemotherapy could have been taken. Okay, but there is no prior endocrine therapy allowed. And you randomize them to fulvestrant, the same schedule which was used in the first study. 500 mg on day 0, 14, 18, and then 500 mg every 28 days, not 250 mg, and compare that to anastrozole 1 mg. What about the overall response rates? Almost same. 78% clinical benefit rate. 3/4 of patients have clinical benefit, be it anastrozole or fulvestrant, with 3% complete responses, almost 40% partial responses. Additional 40% of patients have stable disease. So what does that tell you? Only 13% of patients progress. Hardly 13% of patients progress when you put them on an endocrine therapy. 87% of patients will have clinical benefit, and that's one principal reason why you don't want to use chemotherapy as first line, because out of 10, only 1 patient may experience progressive disease. And looking at the primary endpoint, which was PFS in the Falcon study, the primary endpoint was met. A difference of approximately 3 months. Anastrozole 13.8 months, fulvestrant 16.6 months. So absolute difference 3 months, fulvestrant scores or anastrozole. What about the hazard ratio? 0.79. So 21% reduction in the risk of progression. Number 3, the 95% CI, is it crossing 1.0? It's stopping at 0.999. And lastly, p-value is less than 0.5. So all the 4 factors have been met. Now you try to look at one more subgroup and something interesting came out. In the first study, what was interesting was no prior endocrine therapy, Faslodex works better. In the Falcon study, if you do not have visceral disease, these are the patients who maximally gain and benefit by using fulvestrant. If you don't have visceral disease, hazard ratio is 0.59, and from say above 1 year with anastrozole, it touches almost 2 years with fulvestrant. In those patients with visceral disease, there's hardly any difference. So if your patient, the Falcon study showed you that if your patient does not have visceral disease, the quantum of benefit by using Faslodex is much, much more when compared to anastrozole. Having said that, even in patient with visceral disease, it's as good as anastrozole. Overall, in the entire population, the primary endpoint of improving the PFS was met. And therefore, in endocrine therapy, naive ER positive MBC, fulvestrant, Faslodex scores over anastrozole. Now, this is the subgroup analysis. And as you can see down in the bottom, those who have visceral disease, the diamond is sitting exactly on unity. So, adverse events. Almost all adverse events are in single digits. Sometimes 11% of patients may have some nausea, some fatigue, some hot flashes, and around 17% of patients may have arthralgia. If you compare all these adverse events with the anastrozole arm, it almost always closely matches, essentially no difference between anastrozole and fulvestrant with regard to the adverse events, incidence or severity. And therefore, anastrozole versus fulvestrant, with regard to efficacy parameters, fulvestrant scores over anastrozole. With regard to toxicity, it's as good as anastrozole. So maximal efficacy against the disease and minimal toxicity is the goal of treatment in medical oncology practice, which the first and the Falcon study confirm by choosing fulvestrant over anastrozole. Now, the previous section, we spoke about the trial which compared fulvestrant 250 mg to anastrozole. And in this section, we spoke about 2 trials which are comparing about fulvestrant at a higher dosage, 500 mg. So the first and the Falcon is 500 mg day 0, 14, 18, and every 28 days Faslodex. Study 20 and 21 was 250 mg every 28 days. Now, for 250 mg versus anastrozole 1 mg, both were equal, at least as effective. But when it's the standard, when it's 500 mg, then it is superior. Let's therefore try to head-on compare Faslodex 250 mg schedule to the fulvestrant 500 mg schedule. And that is the confirmed trial which looks at Faslodex 250 mg every 28 days versus Faslodex 500 mg day 0, 14, 18, and then every 28 days. You look at 736 patients. Now, with regard to statistics, a good trial in medical oncology practice in advanced breast cancer is one which has at least 700 to 750 patients. So that is if you're looking at a trial in medical oncology practice in advanced breast cancer, then look at the numbers of patients in the trial. If the numbers are 700 or 750 and above, then that is a robust data because it will definitely stand up to statistical significance. You had 736 patients here randomized 1:1 to Faslodex 250 schedule or 500 schedule primary endpoint PFS. a significant increase in the PFS when you choose fulvestrant 500 mg over 250 mg, 5.5 versus 6.5 months. It might look at the 1 month difference, but look at the hazard ratio. 20% reduction in the risk of progression, 0.80. Number two, does the 95% CA cross 1.0? It stops at 0.94. Thirdly, what about the p-value? Is it less than 0.05? It's 0.0006. So confirm results, confirm the advantage of fulvestrant 500 mg. It also translated to an advantage in overall survival. You can count on fingertips the trials in metastatic breast cancer where you find an OS advantage. This is one such study where you find significant increase in OS, almost a 4-month advantage, hazard ratio 0.81, 95% CI is 0.69 to 0.96, and the p-value is significant. The primary endpoint was PFS, primary endpoint met. Clinically significant, clinically meaningful, and statistically significant improvement in the PFS, and so also in the overall survival. And so it significantly increased the PFS and OS. In the US in 2002, the FDA approved fulvestrant 250 mg dose. When these results came out, after study 20 and 21, 2002 US approval, after Falcon, and then the confirmed data in 2010, a license change happened, and now Faslodex is used by all of us in the dose of 500 mg day 0, 14, 18, and then every 28 days. You look at the NCCN guidelines. For first-line treatment and subsequent line therapy, you can use single-agent fulvestrant. Okay, so standard schedule of fulvestrant, my third take-home message, should be 500 mg on day 0, 14, 18, and then every 28 days thereafter. We have the confirmed data and the first and the Falcon study, which led to the confirming this standard schedule. Section 4 of my talk, CDK4/6 inhibition, so beautifully discussed by both the previous two elegant speakers. It is a drug target in ER-positive breast cancer, which is now validated, and endocrine therapy and CDK4/6 inhibitors have complementary modes of action. Without going into more details, let's understand that we have broadly 3 trials with the 3 molecules. The Paloma trials look at palbociclib. The Mona Lisa trials look at ribociclib, and the Monarch trials look at abemaciclib and combine that with endocrine therapy. And these are the timelines and clinical data in the last, say, approximately last decade when these molecules cropped up. And they changed the way, our dimension of how we approach first-line treatment. Paloma 3, these were patients who progressed on prior endocrine therapy or within 12 months of adjuvant treatment or on treatment for advanced breast cancer. Palbociclib plus fulvestrant compared to fulvestrant. It's important to know in the Paloma 3, when you do a cross-trial comparison, 1 or more chemotherapy regimen was used in Paloma 3. So these are patients who have been exposed to chemotherapy also. So a more bad population. The primary endpoint was PFS, and Paloma 3 showed adding palbociclib to fulvestrant gives you a PFS advantage. It also improved the OS by 7 months. So palbociclib and fulvestrant versus fulvestrant alone, Paloma 3 data, you have a 7-month advantage in the overall survival. What about Monarch 2? You're looking at an endocrine therapy resistant population. Unlike Paloma 3, you're looking at patients who have not received chemotherapy for advanced breast cancer. And like Paloma 3, you are comparing fulvestrant and abemaciclib to fulvestrant alone. To again find in the second line subgroup, in patients who are receiving a second line, there is an advantage in the median progression-free survival, 10-month advantage, 7.5 months to 17.5 months. What about an OS advantage? Yes, almost a 12-month advantage, 40 months versus 51 or 52 months. Lastly, looking at Mona Lisa 3. Again, like the previous trial, like Monarch, you are having patients who have not received chemotherapy, unlike Paloma 3. 726 patients, either no endocrine therapy or one line or less than one line of prior endocrine therapy. Now you're looking at fulvestrant, comparing fulvestrant to fulvestrant plus ribociclib. And then again, you find in second line, there is an advantage in progression-free survival and also improvement in the overall survival. So all the three molecules, each one of them with fulvestrant, gives you an improvement in the progression-free survival. The absolute numbers are different in each of these trials. That's because of the trial population. For example, fulvestrant plus palbociclib, the median PFS is approximately 9 months. Ribociclib plus fulvestrant, it's around the median PFS is around 14 months. And abemaciclib is 17.5 months. That's because the trial populations in the study were slightly different. What's striking is the hazard ratio. The hazard ratio is 0.50 to 0.57. So that's important. Fulvestrant alone versus fulvestrant plus a CDK4/6 inhibitor. Different patient populations may vary, but all of them stand to benefit equally. Almost a 50% reduction in the risk of progression. So as second line, in the second line setting, you plan to choose fulvestrant, well and good. If you can add a CDK4/6 inhibitor to fulvestrant, the hazard ratio becomes 0.50, 0.54 or 0.57. So choose whichever CDK4/6 drug you want to choose. But fulvestrant has to be there as second line. Only then you end up having a PFS and an OS advantage. So a later line, second line combos of fulvestrant with CDK4/6i gives you a hazard ratio of 0.50 to 0.57. It is not possible to remember the absolute numbers in clinical practice. So many trial data coming up. To your patient, what do you tell? To the patient, you can discuss that you take fulvestrant versus add fulvestrant plus CDK4/6i. There's a 50% more advantage of adding fulvestrant because the hazard ratio is 0.50. Choose whichever CDK4/6i you want, depending on the available. Palbociclib recently has lost its patent. And therefore, the drug is now much more cheaper because of generic versions. Choose palbociclib, no problem. Choose ribociclib, choose abema, but fulvestrant is important. To your patient, you tell fulvestrant alone versus fulvestrant plus say palbociclib, 50% reduction in the risk of progression. Therefore, if possible, add, for example, palbociclib. So later line fulvestrant combos with CDK4/6i has that ratio of 0.50 to 0.57. Now coming to the first line setting. And I have showed you all the phase 3 trials there, looking at CDK4/6 inhibition in HR positive, HER2 negative advanced breast cancer. A very busy slide. Forget this. Look at Mona Lisa 3. Fulvestrant plus ribociclib compared to fulvestrant alone. In the first line, the median PFS is 33.6 months. When you choose the drug combination of fulvestrant plus ribociclib, your patient remains progression-free for almost 3 years. One of the longest PFS you have seen in medical oncology practice in advanced breast cancer. So Mona Lisa 3 as first line, ribociclib and fulvestrant, 33.6 months median PFS, one of the longest. What about an OS advantage? Hazard ratio of 0.70. What about Monarch 2, abemaciclib? So here also you had first line subgroup, but this is endocrine therapy resistant population. So here you're an ET resistant population, but still you find a PFS advantage and an OS advantage. So an OS advantage is seen by keeping the backbone as fulvestrant. Whatever the line of therapy, first line or second line, when you combine with a CDK4/6 inhibitor. Okay. So whatever the line of treatment, first line, second line, you can find an OS advantage. Some data is yet to come. I will not say all trials have got their OS data available to us, but by and large, I think the CDK4/6 inhibitors are interchangeable, and that's the advantage of having multiple drugs. As in CML, you can choose your second generation TKI depending on the adverse event profile. And so also in medical oncology practice. Sixth section, there is a trial called as the FLIPPER trial. Now you are now looking at de novo MBC. Patient has come today with stage 4 ER positive, HER2 negative advanced breast cancer. Or you are looking at a recurrent endocrine therapy sensitive MBC. So ET sensitive, not ET resistant, and you randomize them to fulvestrant, palbociclib, or fulvestrant alone. De novo MBC, the median PFS is 33.4 months. So you had patients who were de novo MBC, palbociclib, fulvestrant, 33.4 months. Almost the same which you saw in the Mona Lisa trial with ribociclib, fulvestrant. A recurrent MBC, 30.5 months, in excess of 30 months. Visceral disease, again, more than 30 months. Non-visceral disease, again, more than 30 months. And if you look at the PFS at 12 months across all these 4 timelines, in all these 4 subgroups, at 12 months, there is a PFS advantage, whatever be the subgroup. De novo MBC, a recurrent MBC, visceral disease, non-visceral disease, you are finding at 12 months a PFS advantage. In absolute numbers, the PFS is more than 30 months. So palbociclib plus fulvestrant improved the PFS at 1 year and the median PFS in pre-specified subgroups versus the placebo arm. And therefore, it comes a question, can we use a CDK4/6i plus AI or a CDK4/6i plus fulvestrant in the first line setting? Because the FLIPPER data looks very encouraging. We therefore try to look at a trial called as the Parsifal, which tried to answer this question specifically. Endocrine sensitive patient population randomized to fulvestrant palbociclib versus palbociclib plus an AI like letrozole. And the speculation was that fulvestrant is a better drug, is a stronger drug, and therefore you might end up having an advantage over a CDK4/6i plus letrozole, as in the FLIPPER study, for instance, visceral disease or non-visceral disease. In patients who had non-visceral disease, both of them were equal. In patients who had visceral disease, letrozole palbociclib was better than fulvestrant palbociclib. Now remember, fulvestrant in previous studies also have shown that in patients with visceral disease, in a bad biology patient, it doesn't really work that much. But you're finding actually a detriment here. Then by disease presentation, de novo or recurrent, again, essentially no difference statistically between fulvestrant plus letrozole or fulvestrant plus palbociclib or letrozole palbociclib. You look at various pre-specified subgroups. The diamond in all of them is to the right, almost all of them, except those patients who got a prior AI. So The conclusion was Parsifal study was inconclusive in establishing superiority between the two endocrine backbone agents when combined with palbociclib. Final treatment decisions can balance patient initial preference as well as subsequent treatment strategies. So it's not like as if that option is completely out. You can use fulvestrant plus a CDK4/6 as first line also, depending on which patient population and the patient preference is. And that's why in the NCCN guidelines too, you find preferred regimen as first line treatment, fulvestrant plus a CDK4/6 inhibitor as a category 1 recommendation. So de novo or recurrent ET sensitive MBC, a back step happened with fulvestrant with the Parsifal study results. As first line, Faslodex plus CDK4/6i plus in some patients, minus in some patients. Requires physician and clinician preference and patient preference. Seventh part, I told you 8 messages. Seventh section is to talk about the Monarch HER study. You might have patients who are triple positive, ER positive, PR positive, and HER2 positive. And HER2 positive MBC patients have received, say, trastuzumab-based chemotherapy as first-line treatment, and then they have received a taxane as second-line or third-line. They have received TDM1 also. And then you randomize these patients to trastuzumab plus some chemotherapy, or trastuzumab plus abemaciclib because HR positive disease, or trastuzumab plus abemaciclib and fulvestrant in this resistant patient population. So HR positive, HER2 positive, fulvestrant plus trastuzumab plus abemaciclib. Overall response rates, 1/3 of patients, more than 1/3 of patients respond to triplet combo of fulvestrant plus trastuzumab plus abemaciclib. One more treatment option to choose in your patients of HER2 positive or TPBC, triple positive breast cancer. The primary endpoint PFS again showed a significant improvement, 8.5 months versus approximately 5 months. So around 2.6 month advantage, significant statistically. Well, that was just to let you know what the flavor of triple positive breast cancer can be. Estrogen receptor has many isoforms. The main isoform is estrogen receptor alpha. When you put a patient, which is the gene which encodes ER alpha? The ESR1 gene encodes ER alpha. If your patient is on AI or an AI plus a CDK4/6i, for instance, resistance develops mainly because of activating mutations in the ESR1 gene. How many percent of patients? Approximately 40% of patients who are ER positive, HER2 negative on an AI, when the AI fails and you check, you find they will be having ESR1 mutations. You can do this by a simple blood test. A blood test looking at circulating tumor DNA to find out if they are ESR1 mutations or not. All patients who walk into you today for HR positive, HER2 negative advanced breast cancer, you do at baseline, the incidence of finding an ESR1 mutation is less than 3% or 3.5%. You put the patient on AI alone or AI plus CDK4/6i, when progression happens after, say, 12 months or 28 months, respectively, you again check the blood test. 40% of these patients would be having a ESR1 mutation. So blood BESR1 mute stands for blood ESR1 mutations. And when the ESR1 mutation is present, fulvestrant works. Because now you don't require the DNA binding domain or AF1 or AF2, because ligand dependent or independent, this drug will degrade the ER. So mutations don't matter. And therefore, fulvestrant mutant ER alpha cells are sensitive to fulvestrant. PADA-1 was a trial, PADA-1 in France across 83 hospitals, a phase 3 trial. It had 2 steps. The first step in the study was patients who had not received previous systemic treatment for advanced disease, so keep treatment naive, or never received adjuvant AIs, or they may have received but more than 12 months should have passed. So these are patients who can be labeled as endocrine therapy naive, or even if exposed, more than 12 months have passed. And what do? You check on day 0 the blood ESR1 mutation levels by the PCR technique, looking at hotspot on 380, looking at all these hotspots codons to find out at baseline is the patient having ESR1 mutations. And then you keep on checking the mutations after 1 cycle, and I think once in 2 cycles. So the patient starts on an AI, for example, you check the ESR1 today, and then the patient continues on AI plus CDK4/6i, for example. Every month, for the first month, after 1 month, check the ESR1, and then every 2 cycles. When progression happens, whenever you're checking it, you find that the levels are rising. You now find an ESR1 mutation, say after 12 months. Inform the patient that now your blood is showing ESR1 mutations in the ctDNA. Then do a complete staging workup to find out if there is progression radiologically on the CT scans or the PET. And if there is no disease progression on the CT scans, then what do? Second step. Because there is no evidence of radiographic progression despite presence of mutation, continue the same AI plus CDK4/6i, or because you're finding, so continue the CDK4/6i, stop the AI, and put this patient on fulvestrant. Okay. Second step is very important. You are checking the blood ESR mutation levels. It's stable, and then on the CDK4/6i and the AI, progression is happening only in the blood, but all scans are normal. You randomize these patients into the second step. Now here, you're switching to fulvestrant palbociclib versus continuing palbociclib and an AI. Now, this publication came just less than 6 months back, but it's interesting to know that I would call this as the 60 trial, the 60 trial. 60 median age around 60 years, 61 years. 60% of patients were a recurrent disease and not newly metastatic. 60% of these patients had not received AI in the adjuvant setting. In 60% of them, after 12 months, the blood ESR1 mutation levels showed progression. 60% of them had ECOG PS of 0, and 60% of these patients at progression had 3 or more than 3 metastatic sites. And therefore, almost everywhere you find 60%. And what is the advantage of switching to fulvestrant and palbociclib versus continuing AI plus palbociclib? Hazard ratio is also 0.60. So when you, after progression, you switch the patient to fulvestrant and palbociclib, then you find these patients have a longer PFS with a 40% reduction in the risk of progression. So serially checking the ESR1 levels will make you add fulvestrant and give a 40% advantage. In absolute numbers, less than 6 months becomes close to 12 months, a doubling of the PFS. And these are all pre-planned subgroup analysis. And as you can see, in all the pre-planned subgroups, all of them stand to benefit by adding fulvestrant to a palbociclib and changing it, switch it, rather than continuing. Whenever you find ESR1 mutation, you can find that patients who are bone only there, the diamond is to the right. But that's because very small numbers of patients, and therefore you can't come to a conclusion that their fulvestrant doesn't work. What I'm trying to impress upon you is that fulvestrant as second-line therapy, previous trials, what we discussed, or in that arm where the patient were continuing, you start the patient today on palbociclib AI. after 12 months, ESR mutation present. You continue the AI and the palbociclib only. The drug works for 3.5 months only. And that's what the Emerald trial also showed. So if there are mutations present in the blood, then you continue same treatment. Only after 3.5 months progression is going to happen. You switch, it will become almost 12 months. The reason why I thought I should let you know this is because using fulvestrant early on seems to be the future. The moment you detect an ESR mutation, rather than having disease signs present and then changing, using it early on gives you a much more advantage. So ESR1 mutation serially rising during an AI plus CDK4/6I change to fulvestrant plus palbociclib. My last section, I told you about 8 take-home messages. What have we achieved with endocrine therapy in the first line setting? We look at the PFS. That's an important surrogate marker and tells us what the drugs can do. How long does tamoxifen work in patients who receive first line endocrine therapy tamoxifen? It works for approximately 6 months or 8 months at the most. So tamoxifen, the PFS in first line ET MBC, it is an MBC 6 months. What about an AI? Overall population, it gives an advantage of another 2 to 4 months more over tamoxifen. So 6 months tamoxifen can become 10 months by using anastrozole or letrozole. But if it's an ET sensitive cohort, then it's 14 to 15 months. So 6 months, then 10 months. If it's only ET sensitive, it becomes 14 to 15 months. Only fulvestrant sensitive population is better than an AI, 16.6 to 19.2 months. We discussed about these trials. So fulvestrant in the ET sensitive cohort, 16.6 to 19.2 months. And then the response rates are 40% in those patients who have measurable disease. If it's an CDK4/6 inhibitor available and you add it to an AI, definitely it's better than fulvestrant. It becomes more than 2 years, 25 to 28 months. I spoke about the Mona Lisa 3 trial and also about the phase 2 study. Now, if it's in those patients measurable lesions, 50% response rate. So 10% advanced fulvestrant, but fulvestrant plus ribociclib, the median PFS is 33.6 months. So this is how we have gone on to improve the PFS in medical oncology practice. 6 months tamoxifen in 1990s is now almost close to 3 years by using fulvestrant plus ribociclib in an ET sensitive population. Lastly, example of a sequencing strategy for HR positive, HER2 negative metastatic breast cancer. As first line, you may use an AI plus CDK4/6I. When progression happens, you can check for the PIK3CA mutation status. 40% of patients are PIK3CA mutant. When progression happens, fulvestrant plus alpelisib if PIK3CA mutant. As third line, you can use the Bolero data, everolimus plus exemestane. So 3 lines of treatment, endocrine therapy only. And all 3 are combos. AI plus CDK4/6I, first line. Second line, fulvestrant alpelisib. Third line, exemestane, everolimus. And then you can use single agent chemotherapies like taxane, like capecitabine, and then eribulin. Sir was mentioning about the HER2 low category. As he rightly mentioned, that is what is now being discussed across all medical oncology circles. HER2 low, use a drug by name trastuzumab deruxtecan. If you by chance do a genomic profiling after 3 lines of treatment have failed, and if HER2 is found a mutant, then neratinib. HER2 low, trastuzumab deruxtecan, HER2 mutant, neratinib, and later, when these 2 fail, you can still think of using sacituzumab govitecan. So that's how we are progressing in oncology. Now, Second scenario, as first line AI plus CDK4/6i, but PIK3CA mutation is not there, 60% of patients. Then you can use fulvestrant alone, or you can use fulvestrant everolimus. As third line, then exemestane alone. If second line was fulvestrant everolimus, or if second fasciitis alone, then third line is exemestane, and then the further fourth line remains the same. ESR1 mutations. As I told you, some of your patients, if by chance, I think that's one area where possibly AstraZeneca can try to see if they can help you in getting all your patients serially tested for this test, the baseline blood ESR1 mutation levels. If it's been baseline, then 3% of patients, less than 3%, you may think of using fulvestrant plus a CDK4/6 inhibitor. Or if your patient is on CDK4/6i plus AI, palbociclib and Arimidex, at progression, whenever progression happens, you're checking serially, all scans are normal, you switch the patient to palbociclib and fulvestrant. So that's the third way. Fourthly, as first line, therefore, if you give the patient fulvestrant CDK4/6i, as second line, it can be exemestane everolimus. As third line, you by chance get a BRCA mutation present, then you can use talazoparib or olaparib. Then fourth, fifth line, again chemotherapies. In fact, if you have a BRCA mutation present, then you can use olaparib as second line, as third line, as fourth line. So one more drug to use in the kitty before you put your patient on chemotherapy. And that's why some of the guidelines, some of the authorities check for a BRCA mutation in all patients of MBC and not just triple negative breast cancer or young patients. So you can check your patients for a BRCA1, BRCA2 mutations in all patients. And when that happens, as second, third, or fourth line, you can still use an oral drug. So we are here today to discuss about Faslodex. What all I discussed with you in the last approximately 45 minutes or so can be remembered by remembering Faslodex. Faslodex is fulvestrant. That was my first take-home message. AI versus Faslodex 250 mg, study 20 and study 21. Faslodex 250 mg is equal to Arimidex. Standard dosing of Faslodex should be 500 mg on day 0, 14, 28, and then every 28 days. The confirmed study and the first and the Falcon study. Later line, second line combo with a CDK4/6i, whatever the CDK4/6i you choose, the hazard ratio is 0.50 to 0.57. I showed you the table, be it palbociclib or Abema or ribociclib. Fulvestrant is the backbone. Choose whichever you want. Whatever patient population second line, hazard ratio is 0.50 to 0.57. OS advantage has been seen with this molecule fulvestrant. In first line, in second line, either singly or in combination. Some data is still emerging. De novo or recurrent endocrine therapy sensitive MBC, Faslodex combination with CDK4/6i. I think I leave it to the clinician and the patient to decide to take an injection or an oral pill. ESR1 mutation, serial monitoring makes sense. If possible, try to utilize that, the PADA1 trial. Lastly, example of a sequencing strategy was shown to you as to how incorporating various biomarkers can help you. So that's Faslodex from me to all of you. And those are the 8 important take-home messages. And with that, I think I'll close, unless you are all eager to listen to me for a few more minutes. So can I take 10 more minutes? So because I'll finish with a case. This is one more example of a sequencing strategy. A premenopausal female, what do? The moment you have an HR positive, HER2 negative advanced breast cancer premen, the first thing should be you make her postmenopausal. Either you use a drug like Zoladex, or you go for a bilateral oophorectomy. A radiation oophorectomy is not the right way to do oophorectomy. It can be surgical oophorectomy or could be a medical oophorectomy, like an allotorectomy, like Faslodex, like Zoladex. So this was a 43 years old premenopausal female working as a teacher, single, no children, came with a right breast mass and axillary nodes. Biopsy was ER positive, PR positive, HER2 negative, but the PET scan showed visceral metastasis in 3 areas: bone, liver, and lung. The LFTs were altered, mildly elevated. As I told you, don't forget to check the RFTs, LFTs, and the PFTs. You might be having a patient who is in a visceral crisis. In that case, prefer chemotherapy over using the endocrine therapy partners. You can still there also think of using a CDK4/6i plus AI. But I think initial stabilizations, better to switch to chemotherapy for the first few cycles, if not more. So if this patient, is she in visceral crisis? Is it yes? Is it no? Is it may? Because the LFTs are slightly altered, and that's because of the liver metastasis causing some organ compromise. Now, visceral crisis, if the answer is yes, then the chemotherapy becomes standard treatment. But if no, then endocrine therapy, despite such extensive disease, should be the first line of treatment. Less than 10% of patients will progress when you put them on endocrine therapy alone or endocrine therapy combinations. So what can be the preference as first line treatment? Ovarian function suppression is extremely important. Rest, everything else comes afterwards. So that's the first thing you should do. And then you can combine that with an AI alone or a fulvestrant alone or a combo of ET plus CDK4/6i. You look at this data, 2015 to 2018, the use of chemotherapy has steadily decreased and has become almost zero now. Use of CDK4/6i has increased over time. Endocrine monotherapy usage also is decreasing over time. You are now looking at endocrine therapy combinations. You had 2 trials, one was FACT and one was SWOG. They looked at fulvestrant plus Arimidex combination, Faslodex and Arimidex. So you can use single agent endocrine therapy, or you can use endocrine therapy and endocrine combo like Faslodex and Arimidex, or use an ET plus a CDK4/6 inhibitor. The bottom line is it has to be endocrine therapy based treatment. The monotherapy has been coming down steadily across various patients between 2015 to 2018. Does endocrine sensitivity matter when planning strategy? Yes, no, maybe. All of you are nodding your heads. The answer is yes. No prior exposure to endocrine therapy. The patient is endocrine naive. These patients do better, as we all saw in the subgroup data when compared to patients the disease comes back. When it comes back, is it resistance primary, resistance secondary, or is it endocrine sensitive now also? So endocrine sensitivity is very, very important. Number 1, not exposure to prior endocrine therapy, or number 2, at least more than 12 months have passed from the adjuvant usage of endocrine therapy. These are ET sensitive patient populations. These differences in endocrine sensitivity influence the outcome. Proper history is very, very important before you choose a treatment option for your patient. Why does that happen? Because when progression happens, biology changes, new targets can emerge, resistance develops, ESR mutation in 40% of patients. A response to future endocrine therapy also depends on how the first line endocrine therapy worked. And therefore, differences in endocrine sensitivity influence the outcome. We all know if it's an endocrine sensitive cohort, then there is a PFS advantage. The question is, in the upfront setting, can there be some subgroups where you may not want to give an upfront CDK4/6 inhibitor? Is there any patient where you can avoid a CDK4/6 completely? The MONARCH data showed that all subgroups benefit by adding CDK4/6 abemaciclib to an AI. Now, this is like liver mets, yes or no, PR negative, high grade, ECOG PS1, bone only disease, low grade, medium grade, high grade, PR positive, all of them benefit by adding abemaciclib. So all subgroups benefit by adding CDK4/6 inhibitors. And FDA data of 4,200 patients who got a combo of CDK4/6 plus an AI again showed that low risk groups and high risk groups, all of them benefit, whatever be the age, less than 40 or more than 40, all of them benefit. Hazard ratio, you can see it's between 0.51 to 0.64. So 40 to 50% reduction in the risk of progression, whatever the subgroup, by adding a CDK4/6. So not only an individual trial here, which is MONARCH 3, but you also find pooled data of more than 4,000 patients showing the uniform benefit universally of adding a CDK4/6. But in patients who do not have visceral metastasis, I told you we have data. When you don't have visceral metastasis, fulvestrant has an upper hand. So fulvestrant alone, PFS is 22.3 months, close to 2 years. Letrozole CDK4/6 30 months. Fulvestrant CDK4/6 more than 33 months. Looking at the flipper data, which tells you if your patient doesn't have visceral metastasis, fulvestrant gives you a PFS of 33.4 months. So fulvestrant without visceral mets, 33.4 months. Therefore, clinical parameters can help you select if you can avoid a CDK4/6 as first-line treatment. A long disease-free interval, low volume disease, only 2 bones metastasis, lack of visceral disease, low-grade tumor, and less aggressive biology. These are the 5 points. If you jot them in clinic and talk to your patient, you might avoid the costly CDK4/6 inhibitor. This is the only subgroup of patient where, as a clinician, you can decide, I will choose only fulvestrant as first line and reserve palbociclib for later use, and again become more cheaper to us. Or use only an AI and then use an CDK4/6 later. The benefit in absolute terms may very, very less if your patient has all these 5 L's: long DFI, low volume disease, lack of visceral disease, low grade, and less aggressive biology. A few words about alpelisib. PIK3CA mutated HR positive advanced breast cancer. Alpelisib has advantages: the SOLAR-1 study and the BYLieve study. Fulvestrant plus alpelisib. Now, if your patient has a PIK3CA mutation and has not received a CDK4/6, should it be fulvestrant plus alpelisib or fulvestrant plus a CDK4/6? Overall response rate, fulvestrant plus CDK4/6 40%, alpelisib 26% only. Duration of follow-up in the trial 30 months and 40 months. PFS, alpelisib fulvestrant 7.5 months, CDK4/6 fulvestrant 17 months. OS advantage, fulvestrant CDK4/6 more than 40 months, significant statistically. Fulvestrant alpelisib 39.3 months and not significant status. What does that tell you? Reserve alpelisib after a CDK4/6 inhibitor. So clearly you can find that don't use alpelisib upfront, reserve it for second line. With Faslodex, the converse statement can be true. And so my last slide is resistant cohort. What about an algorithm? If it's endocrine resistant cohort, the patient has received a prior CDK4/6I and is PIK3CA mutant. You are right in choosing fulvestrant plus alpelisib. If PIK3CA is wild type, then fulvestrant plus or minus everolimus. Am I clear? If the patient has not got a CDK4/6I, you checked for a PIK3CA mutation also, do not use alpelisib. Primary resistance or secondary resistance. Depending on that, choose your treatment of choice. So this is the algorithm for the endocrine resistant cohort. I am so thankful to Healthcare Mandalar for making me a part of this conference. And what all I spoke about this case, the clinical pearls or take-home messages can be remembered by Mandalar. Menopausal status, don't forget. If it's premenopausal, convert her to a postmenopausal woman. Altered function test, don't forget. Check LFT, RFT, and TFTs. Make sure your patient is not visceral crisis. Naive or not, exposed to endocrine treatment or not, very, very important. Difference in endocrine sensitivity influences the outcome. Therefore, history taking is very, very important. All subgroups benefit with a CDK4/6 inhibitor, but use clinical judgment. Do not forget the 5 L's. Long DFI, low volume disease, lack of visceral disease, low grade, and less aggressive biology. You can choose a single agent hormone therapy like fulvestrant or anastrozole and reserve CDK4/6I afterwards. This is that subgroup which requires clinical judgment by you, and therefore the 5 L's. Alpelisib should be second line, contrasting to Faslodex, and resistant cohort approach should be personalized. So that's Faslodex for you and Mandalar for you. Thank you so much, one and all.
Thank you very much, Dr. Trier. So your lecture is very informative, clear, and succinct. I find every minute of your lecture informative.
Thank you, sir.
And I also admire the way you put across a message to the audience. It's very clear. So it's now time for discussions. So
I think I have been you have been listening very, very patiently. I should thank you to a wonderful audience. I'm so happy that all of you stayed back throughout my long talk. So I'm so thankful to all of you for being a wonderful audience.
So it's worth every minute. So the floor is open for questions and comments and discussions. What time is your flight?
Oh, I forgot. No, kitne baje?
So
I
if you
think
have
we can
ample,
all have a cup of coffee and then sit and discuss.
so if you have ample time to catch your flight, we can sort of make longer discussions. And provided you have also booked this room for a longer period, I don't know where the limitation is.
Yeah, 4 o'clock. No. 4 hoga. Because 12:10 I am reaching Hyderabad. And I think travel also, by
It's
my
all right.
coming, I saw that
Okay.
that was more traffic yesterday. Yes. No, but did you check my flight timings?
Yes.
So I'll break the ice.
Sometimes it happens that all the information has been given to you, so no questions are remaining.
Because your lecture is very clear and informative. There are no questions left to ask. So you talk about KI67 at the very beginning.
Yes,
This
sir.
KI67 is actually very variable. Even in the developed country, UK, US, they find it not very definitive, the demarcation line between low KI67 and high. In the US, they take less than 5% as low and more than 30, definitely high. But previously, low and high demarcation 14%. And now with this Monarch E trial, they make it 20%.
Hmm.
But although FDA guideline include 20% KI67, you will notice that ASCO guideline and NCI guideline does not compulsorily include this KI67 20% as an indication for use abemaciclib.
Absolutely,
So that
sir.
is one thing.
I think I completely agree with sir. And the best part is all of you are completely up to date with the latest in the field of medical
Yeah.
oncology. As sir rightly mentioned, the recent ASCO also tells us clearly that Ki67 is observer dependent.
Yeah.
And therefore, when you keep on removing the slides to 2 or 3, you find differences in the values. We have found that higher Ki67 concordances between pathologists is better. So if the Ki67 is higher, then you find that the concordance is almost like very close to 100%. But at lower Ki67 values, as sir was, the cutoffs have changed gradually, like 14%, now 20% with the Monarch trials, etc. So very, very clear that low Ki67 approach with caution, but high Ki67s, the concordance is almost uniform, and therefore the higher the Ki67, it tells you it's a high grade disease, labeling index is high, and this possibly is a more aggressive biology. Yes. But lower Ki67 should not take you
Yeah.
off guard. Look at other parameters also.
And the beauty of these CDK4 inhibitor is that, especially abemaciclib in Monarch E trial, you'll see that there is benefit in both Ki67 high subgroup as well as in low subgroup. Although that means Ki67 is prognostic but not predictive. In both group, the benefit is substantial. So one thing that surprises me is, although we are talking about 3 agents, CDK4/6 inhibitor, palbociclib, ribociclib, abemaciclib. So we can't actually call abemaciclib as CDK4/6 because the way it works is it covers more than 4 and 6. It covers many other CDK as well, maybe 7, 2, 12, or other things. So abemaciclib is a bit different in terms of CDK inhibition.
Again,
So,
I completely agree with you, sir. With abemaciclib, I think sometimes I also feel, or rather I'm believing, that all CDK4/6 inhibitors are not created equal.
yeah.
There seems to be an edge of abemaciclib over the other 2 molecules. One important advantage of abemaciclib is you dose it continuously.
Yeah, right.
So therefore, the dictum is like, when cancer does not take a day off, why should your CDK4/6I take a week off? With palbo-ribo, 21 days
21,
on, 7 days off. That's because the bone marrow has to recover. The WBC counts have to recover. But with regard to abemaciclib, CDK4 is for breast. CDK6 is for the bone marrow hematopoiesis. Now, CDK4 inhibition with abemaciclib is much, much more than CDK6 inhibition, which is not the case with either ribociclib or palbociclib. And that's why the bone marrow toxicity is not a problem with abemaciclib.
Yeah.
And therefore, you can give the drug continuously.
Continuously.
That's number 1. Number 2, it has been found to have CNS penetration. That's not important, especially in ER positive, HER2 negative patients. But still, the reason I wanted to talk about this was, look at the structure of abemaciclib. Like bortezomib has boron. We very rarely hear about boron in our oncology
Mm,
practice. Similarly, in fulvestrant, we have fluorine atoms attached, which is not with either abemaciclib or ribociclib. So fluorine attached to abemaciclib in the pharmacology makes it able to penetrate the blood-brain barrier. There were two important reasons why abemaciclib was developed in Alcobendas in Spain laboratory. One was, can we make continuous dosing feasible? And second was CNS penetration. And both of these were achieved by using abemaciclib. Thirdly, again, as Sir rightly mentioned, it inhibits much more than CDK4. It inhibits other CDKs, especially CDK9. And CDK9 is important in the intestinal transport. And therefore, you find diarrhea with abemaciclib. Abemaciclib causes diarrhea because it's also, unlike the other two molecules, a CDK9 inhibitor. But that is a side effect, which again, as all of you must have seen, after a couple of months, the adverse event essentially drops down to less than 5% and the body gets used to it. Don't also forget, we are now looking at new drugs and we are used to checking the lab parameters, and creatinine LFT is going up and down, you start getting worried. With abemaciclib, it inhibits the renal secretion of creatinine. You check creatinine, it will go up. And then you would want to reduce the dose, or you would call the nephrologist, not realizing that abemaciclib is harmless. It doesn't affect the filtration at the glomerulus. It only inhibits the tubular secretion of creatinine. And the creatinine is not like 3, 4, 5. Usually it's 1.8, 1.9, 2.1. So a creatinine rise will panic your patient. Reassure the patient, tell them unlike palbociclib and unlike ribociclib, with abemaciclib, creatinine rises do happen. They stabilize and stay between 1.8 to 2.1, and that requires no intervention. So what do? You check the GFR. The GFR will be normal. Or you check serum levels of cystatin C, which is a marker of filtration glomerulus. That will be normal, telling you that abemaciclib is causing this. With regard to some of the lung molecules also, as Madam and Sir were discussing, tepotinib, capmatinib also are these MET transporters inhibitors. So for MET altered exon 14 skipping non-small cell lung cancer, you use tepotinib, capmatinib, and these two drugs also cause the creatinine to go up. Don't worry about it. So very beautifully you summarize the advantage of abemaciclib, and that's why possibly it is a more tougher CDK4/6i when compared to the other two molecules, and that's why you are finding an advantage in the adjuvant setting also. The recent 4-year update tells you that the advantage is now 7.5%, 7.5% improvement now with adjuvant abemaciclib.
Okay.
Speak up.
Very informative presentation. In our country, resource is limited.
Yes.
And would you tell me about the optimal duration of fulvestrant in our setting? And what will be the optimal duration?
Yes.
And
So at this,
optimal means the less side effect and less cost.
So one thing I think all of us in common as medical oncologists or treating oncologists believe that I want maximal efficacy against the cancer, but I want minimal toxicity to my patient. So as far as the second part is concerned, the adverse event, fulvestrant adverse events is essentially equal, similar, or identical to Arimidex or anastrozole. So don't worry about the adverse event part. Then what is the problem? It has to be given intramuscularly. It's an oily injection, therefore painful. But that too, maybe for a day or so. Otherwise, it's an excellent molecule. And again, it's a very thick oily suspension. So therefore, you might have to train your staff so that they know, they don't panic. when they're giving the injection intramuscularly. Otherwise, as far as efficacy is concerned, it's actually better, equal or better, 250 versus 500 respectively. I think we have discussed that with the first study, the Falcon study and the Confirm study. And sorry, 20 and 21 telling you 250 mg is not the right dosage. Now, how should we continue? As far as endocrine therapy is concerned, as all of us know, it should be continued till progressive disease. And that may be financially troublesome. So what you can do in your practice is, at this point of time, stick to standard guidelines and not deviate from the guidelines. And that is what I think I would suggest to all of you. See, as long as things are smooth and good, patients don't complain. But by chance, if progression happens very early on, then the question comes, suboptimal dosage by you possibly caused early progression. So at least we should be clear in our minds that if finances are a constraint, in that case, choose an AI or tamoxifen, exemestane, whatever. Otherwise, use Faslodex as it should be used. Only thing I can tell you, adverse events are in single digits. 11% of patients may have some nausea, some fatigue. 17% of patients may have some mild or moderate arthralgias, self-limiting adverse events.
Thank you.
Do check for the liver function test and the kidney function test, because if your patient has hepatic impairment, then you don't stop the medicine. You should be cautious and see it doesn't keep on worsening. If your patient has severe kidney impairment, then again, no contraindication, but be cautious about the drug and how the patient is responding to it, how the patient is taking it. Otherwise, there should be no problem at all.
So we have a couple of questions from the audience. The first question is already answered. Side effects of and current toxicity of fulvestrant, you have already answered that. And second question is also answered already. How long do you have to give in the metastatic setting of breast cancer?
I think in all advanced cancers, we have realized we will use the drug till progressive disease.
Yeah.
That's the way it should be. Let me again sort of give you we have time, sir?
Yes,
Yeah.
we do.
So for example, if you have a HER2 positive metastatic breast cancer today, right now, HER2 positive MBC patients, we give them only chemotherapy, either combinations or single agents. How long will they live? The median survival is around 18 to 20 months. Now, HER2 positive MBC, you give them chemotherapy, a taxane plus trastuzumab. How long will they live? You had initial Dennis Lamon trial, paclitaxel plus trastuzumab or AC plus trastuzumab. And then you have the Michael Marty trial, which was docetaxel plus trastuzumab. 30 months. So adding trastuzumab to chemotherapy will improve the median OS from 20 months to 30 months, 29 to 31 months, 29 months ISC 3+ patients, paclitaxel, trastuzumab, Dennis Lamon, 31 months Michael Marty, docetaxel plus trastuzumab. In both the trials, they gave 6 cycles of chemotherapy and then stop and wait and watch. Third came the Cleopatra trial. HER2 positive MBC, pertuzumab plus trastuzumab plus docetaxel, 56.5 months median overall survival. So from 20 months, it's almost close to 5 years now.
Yeah.
Now the second arm in the Cleopatra was docetaxel plus trastuzumab. And the experiment was docetaxel, trastuzumab. So this gave 56.5 months. The control arm, it was 40.8 months. So docetaxel, trastuzumab, taxane, trastuzumab in the previous trials gave you an OS of 30 months. How come in the Cleopatra trial, the control arm is 41 months? That was because of 2 important reasons. Number one, docetaxel was continued along with trastuzumab till progressive disease.
Mm.
You didn't stop the chemo 6 cycles. The median number of cycles was 8. And some of them went on to get as high as 42 cycles in the doublet of docetaxel trastuzumab. And in the THP arm, some of them went on to get 52 cycles of docetaxel. So median number. So therefore, chemotherapy also, if you can continue as long as the patient can tolerate, then it further adds on and 30 months becomes 41 months. So in endocrine therapy, for sure, it is still progressive disease, be it fulvestrant alone or fulvestrant plus a CDK4/6 inhibitor. And hardly any patient discontinues Faslodex because of an adverse event.
So you have to give as long as there is a response. Yeah.
Yes. As long as progression does not happen, there's
Yeah.
clinical benefit. Yes.
And until intolerable side effects.
Yes, sir.
Yeah.
Yeah. Yes.
So the third question is, what is the data on monitoring during treatment with fulvestrant?
Okay.
So is there any cardiac toxicity specifically asking about
Cardiac adverse
toxicity?
events.
Yeah.
Now, this drug, in a way, is a pure anti-estrogen. This drug is a selective estrogen receptor degrader or downregulator or a destroyer. And therefore, it works only on the ER component. Adverse events with regard to cardiac adverse events are unheard of, or even if they happen, they possibly were by chance as a coincidence. So cardiac events or cardiac adverse events should not be a cause of concern with abemaciclib. Thromboembolic complications also are unheard of. However, with the CDK4/6 inhibitors, you can have thromboembolic complications. So if it's fulvestrant plus CDK4/6I and your patient by chance has a thromboembolic complication and you want to stop, which one will you stop? The CDK4/6I, not fulvestrant.
Right.
So that's an important take-home message. Many of our patients are on DOACs, directly acting oral anticoagulants like rivaroxaban, etc. They can have a drug-drug interaction with palbociclib, ribociclib, but not with fulvestrant.
Yeah, out of 3 agents, CDK4/6 inhibitor, as far as I remember, ribo is something to do with QTc prolongation.
Yes.
And like you said, abemaciclib is thromboembolism. Yeah.
Diarrhea.
Diarrhea plus
Thromboembolism, 3% of patients. Yeah.
Okay. So
I think that's a relevant point, sir, brought out. QTc prolongation is seen with ribociclib. Don't forget to get the ECG. And I think that's the advantage of having 3 drugs.
yeah.
You can choose inhibition of CDK4/6, but look at the adverse events and then decide which one to choose. Always get a ECG done. If it's showing QTc prolonged more than 480 milliseconds, don't choose ribociclib. Simple.
The fourth question is, after AI is given, can you give Faslodex? Yeah, you can. Doctor has
Absolutely.
already
You
mentioned.
should, you must give Faslodex as second-line treatment for sure, be it either alone or in combination with CDK4/6I. It could be fulvestrant plus alpelisib if it's PIK3CA mutant. It could be fulvestrant plus a CDK4/6I if not used in first-line setting. It could be fulvestrant plus everolimus if it's AI and CDK4/6I in the first-line setting. And I think these are all the options here, but fulvestrant remains.
And looking at the data, the way the data are going at the moment, it seems like AI may even be a thing of the past in the long run, and this Faslodex will be the way for the future.
I clearly mentioned in one of my messages that physician preference clinician preference and discussion patient may make you choose fulvestrant-based combination as the first-line treatment
Yeah.
to give you a median PFS of 33.6 months, 3 years.
Yeah, 3 years.
Yeah.
And that will also save you repeated testing for this ctDNA as well.
If you want to do that, then you don't
Yeah.
require it. Yes. It
Yeah,
works
talking-
irrespective.
Yeah, talking about ctDNA reminds me of one other trial, that is CHARP trial. So they analyzed 83 patients. Out of them, 8 patients are ctDNA positive 5 years after completing chemotherapy, not immediately after completing treatment. 5 years down the line, they measure ctDNA. 8 patients, they found it positive. Out of them, 6 patients developed metastasis. So this ctDNA is very prognostic value. It has very prognostic value.
As Sir rightly mentioned, I think that will be the future, looking at either circulating tumor cells or looking at ctDNA. We have enough publications now where, say, a CTC cutoff of more than 5 after the anti-adjuvant treatment is possibly a higher chance of getting the disease back. And you check serially as the number keeps on increasing. Then if it's rising, then in the coming 8 to 12 weeks, in the coming 2 to 3 months, the patient is going to show the disease coming back on the CT scans.
Yeah.
And that's what even the PADA-1 trial also was trying to look at. Looking at the blood ESR1 mutation levels at baseline, after a month, and then every 2 cycles thereafter. And then they were able to clearly show that if it's rising and then you see scans are normal, you continue palbociclib and AI. After 3.5 months, progression happens on the scans. But you put the patient on palbociclib and fulvestrant, because targeting that population, which is now ESR1 mutant, then it doesn't come back for a year. So the benefit of palbociclib is maintained when you're able to tackle the ESR1 mutant clones by using drugs like fulvestrant.
Okay.
Yes.
And then you talk about sequencing olaparib, PARP inhibitor and CDK4/6. You prefer CDK4/6 first
Yes.
rather than olaparib.
Yes.
But in one study, they recommend using for BRCA positive patients in metastatic setting. They recommend using olaparib first in view of the results from Olympia trial. So overall survival very impressive. And then after 2 years of this olaparib, then you follow with abemaciclib. So what's your thoughts?
See, as long as we have a biomarker, it's always one more additional drug in the kitty, which will tell us to avoid chemotherapy and push it backwards. So in that way, therefore, I was trying to tell you that be it second line, third line, fourth line, wherever, you can think of using a PARP inhibitor. Usually in my practice, I use it after the completion of, after having subjected the patient to a CDK4/6 combination. But I have nothing against the usage early on, but my tilt has been to use a CDK4/6 inhibitor-based combination first, and then afterwards, at some point of time, incorporate the BRCA inhibitors, the PARP inhibitors.
Okay. Anyway, when you come to individual patients, you have to take into consideration those 7 factors you mentioned at the very beginning.
Yes.
So it depends on doctor's preference, doctor's experience, and patient preference, and financial capacity as well, everything. We have to take into consideration every factor.
I completely agree with you. You look at every single page of the NCCN guidelines, in the bottom, they will mention, these are guidelines only by us authorities. Individual patient preferences and clinician choice will always be respected everywhere. For that particular patient, looking at all the factors, you might choose a particular treatment which may look as not a part of guidelines.
Yeah.
And that's why then documentation becomes important. So jot down
Right,
the
right.
points 1, 2, 3, 4, 5, 6. For example, I said like, for example, a patient is there who has a TFI of more than 5 years. It's come back only in 2 bones. You check and you find that it's a low-grade tumor. Biopsy showing ERPR strong positive, HER2 negative. And even those 2 bone mets are not symptomatic. It was picked up just by chance because he went to an ortho for something else, got a scan done, and the MRI picked up these lesions. You confirm in biopsy. So you jot down all those points. Then therefore, in view of this, I am avoiding a CDK4/6i and I'm choosing only a single agent endocrine therapy. And then you write the prescription, there won't be a problem because our colleagues, the patients do go for second, third opinions. So they should know why you chose this. Otherwise, they would say, I would have preferred using the doublet of CDK4/6i plus A, and then controversy starts. So if you jot down why you are not following the usual practice in this particular patient, then your colleague will know the thought which went in choosing that particular treatment. And then there'll never be a problem.
So in this context, it's very important to remember that guidelines are just guidelines. They are not supposed to be followed verbatim, word for word. So you have to alter the circumstances, treatment strategy, depending on so many factors like Dr. has mentioned. So that is what we call individualized treatment. Actually, these guidelines are not static. They are dynamic. They are changing each and every moment. So you need to use your judgment and experience when it comes to individual patients. So any more questions, comments?
Yes, madam.
Thanks, Chairperson and both speaker for very informative update on management of hormone receptor positive breast cancer patient. I'm junior specialist, and one of my question is actually the question from my colleague, another colleague. We are not common, but occasionally we see patient with estrogen receptor negative, progesterone receptor PR positive patient, or either HER2 positive or negative. As you mentioned before, the hormonal treatment mainly add on estrogen receptor. So for this patient, what are the considerations for giving treatment or
So
hormonal treatment to them?
This is ER and PR negative, madam.
Yeah, thank you.
Okay. So ER, PR negative usually will not.
ER negative, PR positive.
PR positive.
Yeah.
Okay. So ER negative, PR positive, and if it's HER2 negative.
Yeah.
For example.
Yes.
So PR positive and ER negative is extremely rare. You have to go back to the pathologist and tell him that something is wrong in the way the interpretation of PR has been done or ER has been done. Because ER negative, PR positive combination is a very, very, very rare. And therefore, in the block somewhere, something in the fixation or the way the interpretation happened was wrong. But then number 2, if it is still ER negative, PR positive, and HER2 negative, if less than 10% of cells are PR positive in that report, please take it as triple negative and treat the patient as triple negative breast cancer only. Okay. Even for ER also, almost all the recent trials are talking as the cutoff as 10%. Okay. But if it's PR positive and ER negative, approach with suspicion, talk to the pathologist, tell him to relook and again give the report to you. Still, if it's positive, then PR less than 10%, take it as triple negative. If it's HER2 positive, then ER negative and PR positive, I'll disregard that and treat as hormone receptor negative, HER2 positive metastatic breast cancer. And then the algorithm is known to all of us. Is trastuzumab plus pertuzumab based chemotherapy as first line, which in India, 2 out of 10, only 2 or 3 patients bring it. So almost always we end up giving a doublet of trastuzumab plus chemotherapy as first line. Recently, a year back or so, we had generic version of Kadcyla. And from then onwards, we're able to use Ado TDM1 in more and more patients.
Okay.
So if it's HER2 positive, then treat as HER2 positive MBC, take it as ER negative, PR positive, disregard that. If it's triple positive breast cancer like ER positive, PR positive, and HER2 positive, then in that case, what I do is that I don't continue the chemo like to trouble the patient. So Perzeta continues, trastuzumab continues, chemotherapy stop the moment you find adverse events are troubling slightly. Don't wait for grade 3 adverse events and put the patient on trastuzumab plus, say for example, letrozole and anastrozole.
Thank you.
Thank you.
When it comes to hormonal analysis, so if it is less than 10%, it's not reliable at all. So in some study, they even use more stringent criteria like ORAD score. So it combines intensity of the staining as well as extent of the staining. They combine these two scores, and if it has only certain point, they encourage giving hormonal therapy. If ORAD score is low, they do not encourage giving hormonal therapy at all. So you have to be very critical about ER negative, PR positive. So that is why I said at the very beginning, reliable quality laboratory results are very important. So I have come across on many occasions where there are discrepancy in the reports between one lab and another, between one country and another. So especially for HER2 new analysis. So as you all know, anti-HER2 agents are very expensive. For example, for Herceptin, the whole course may cost you nearly 100, 200 lakhs at least. And if you use triple agent DPH, it will be more. So if you give HER2 negative patient those agents, you'll be wasting the money and the patients will unnecessarily have the side effects. And if you do not give those agents who can afford to those patients with HER2 positive, you will not be treating the patient properly. The patient will not get the best benefit. So that's very important. So that is why I always double check before I give this anti-HER2 agent, not only anti-HER2, also hormonal therapy agents.
Yeah, I think I completely second Sir's statement. In fact, if you keep on talking to the pathology colleagues, it makes a lot of difference. So much so that because they'll understand the importance of using an anti-HER2 target therapy and the cost behind it.
Yeah.
And then you will find that they'll be a bit more lenient in labeling the IHC2+. So you'll find more and more reports coming as IHC2+ because they don't want to miss a HER2 amplification. So if you look at your data after talking to the before the pathologist, then you'll find that HER2, IHC2+ numbers will rise once you educate them, because then they'll be more tilted to be a bit more liberal and not be dogmatic about 1+. Because they may then level 2+, and then the fish may come positive.
Okay.
And then the negativity of HER2 positivity is negated by using anti-HER2 target therapies. Yeah.
Any more comments or questions? So if there are no more discussions or comments, I would like to conclude the sessions.
Thank you so much.
by thanking our great speaker, Dr. Pelani Setia, PS Tetatria. So I'm very impressive by your lectures, and the AstraZeneca company for organizing this symposium, and our local speaker as well, which gave a very comprehensive lecture, and the audience for actively participating in this symposium. So with that, I'd like to conclude this symposium. Thank you.
Thank you so much, sir.
Okay. အခုလိုအချိန်ပေးပြီးတော့ပြောကြပေးတော့ဆရာကြီးဇော်နေတကွာစပီကာများဖြစ်ကြတဲ့အမဒေါက်ခင်သိမ်းမှုနဲ့ဒေါက်တာရီယာကိုအခြေပြုအများကြီးပဲတင်ရှိပါတယ်တစ်ဆက်တည်းမှာပဲကျွန်တော်တို့ပေါ့နော်ဒီ CA breast management နဲ့ကဒီ endocrine therapy မှာအသုံးပြုတဲ့ဒီ fulvestrant injection Faslodex ကလည်းဗမာပြည်မှာရရှိနေပြီဆိုတော့တစ်ဆက်တည်းအတည်ပြုပြစေကျွန်တော်တို့ဒီ fulvestrant injection Faslodex ကိုကျွန်တော်တို့ indication အနေနဲ့ကတော့ HR positive ပေါ့နော်post menopausal woman မှာ advanced or metastatic breast cancer မှာသုံးနိုင်ပြီးတော့ recommended dosage အနေနဲ့ကတော့ကျွန်တော်တို့ဒီ first month မှာတော့ loading dose အနေနဲ့ဒီ500 mg ကို day 0 day 14 day 28မှာအသုံးပြုပြီးတော့နောက်ပိုင်းမှာတော့ monthly ကိုတော့500 mg အသုံးပြုလို့ရပါတယ်လို့ပြောကြရင်းနဲ့ပဲကျွန်တော်တို့ဒီနေ့ကျင်းပတဲ့ update on the management or HR positive breast cancer လေးပေါ့နော်ဒီ symposium လေးကအောင်မြင်စွာပြီးဆုံးကြောင်းကြေညာပြစေပြီးတော့တက်ရောက်ပေးကြသောဆရာမများအားလုံးပြီးတော့ online မှာတက်ရောက်ပေးကြသောဆရာမများအားလုံးကိုလည်းအထူးပဲကျေးဇူးတင်ရှိကြောင်းပြောကြပြစေအားလုံးကိုကျေးဇူးတင်ပါခင်ဗျာ